So what are the new advances in lens technology and lens design? This is the iViews podcast from iNews magazine. Thanks to the sponsors of the show, Mainline Instruments. They provide unmatched service and unbeatable products in eye care technology. But just a reminder, this podcast is editorially independent. We're joined today by Professor Philip Bloom from Western Eye Hospital. So talking about lens design, lens technology, could you please explain what the changes have been recently that impacted you?
Yeah, I've been in the game a long time. When I was a trainee, it was great to offer patients some spectacle independence. Increasingly, we're moving to a situation where we want to give them, if possible, complete spectacle independence. Certainly for distance, and it's achievable now in the NHS with the addition of Toric intraocular lenses. It's by no means universal, but increasingly NHS units are able to put in Toric lenses, especially with a certain degree of astigmatism. And so generally we'll expect to offer patients to be able to drive without glasses after cataract surgery, and that's a great benefit for them. Then increasingly we are now also able to offer them independence of spectacles for other tasks. For example, in a computer age, being able to see a desktop or a laptop computer without glasses. And that's also quite easily achievable, either by monovision or by lens technology that increases the range of focus of these lenses. We've always been used to implanting aspheric intraocular lens, which give very crisp vision, but only in a very narrow focal plane. So we're now moving towards from monofocal lenses to what we call enhanced monofocal lenses, which are, a part of a variety of range of vision lenses. And I always explain it from monofocal to enhanced monofocal, then to the extended depth of focus, then to the multifocal, or that's probably what traditionally known as the trifocal lenses. And now this new class of lenses, the continuous range of vision lenses. And so it's a very exciting space. Of course, most of these lenses are available in the private sector, but increasingly some are available in the NHS. I've mentioned Toric lenses, but many NHS units are now, through their procurement process, trying to offer to our patients enhanced monofocal lenses, and with appropriate management, with mini-monovision, for example, or nano-monovision, as we sometimes call it, we can give a range of vision. And I'm pretty confident now that I can offer patients independence of computer glasses and driving, and actually quite a lot of independence from reading tasks as well.
That's fantastic. And probably something you weren't able to do 5 years ago, 10 years ago, maybe not as sharp, not as crisp vision for both.
Absolutely. I've been putting in what we've called multifocal lenses for over 20 years. These were originally just very unsophisticated bifocal lenses. They worked well, but they had a lot of complications, a lot of, the well-known effects of glare and halos. A statistic I still quote to patients is that 5 to 10% of patients with a trifocal multifocal lens may choose not to drive at night. And that's quite a difficult thing for patients to have to put up with. Increasingly, the newer versions of these extended range of vision lenses are much better for that. And increasingly, we can say to patients, actually, we can offer you a lens that gives you these options without a significant risk of that. It's a really exciting time to be able to do that. And of course, along with these range of visions comes with the ability to correct for toricity or astigmatism as well.
Do you mind me asking, do you find patient demands are increasing now visually for far away reading, computer, normal lifestyles, grandparents, grandchildren?
Yes. We're undoubtedly a victim of our own success. We take for granted now low complications during surgery. We take for granted the accuracy of biometry that allows to assure patients that we will hit them within a pretty narrow range of their intended post-operative refraction. We're getting better at correcting patients who've had previous laser vision correction. And patients now, quite rightly, expect a good result. And so in many ways, we've minimized cataract surgery to be a technical task. It's not really. The skill with cataract surgery is to make it look easy. The honest truth it isn't easy. I'm very pleased to be still part of the NHS, where we train a lot of doctors, and training is absolutely paramount in this. And the UK should be rightly proud of having, I think, one of the most successful training programs that turns out people with the highest level of skill, lowest rates of complications, and that should be taken for granted. So now cataract surgery is regarded as just a technical task, and it goes without saying that people who do it, either in the NHS or privately, are good at doing that. Again, cataract surgery is rightly regarded, or should, in my opinion, be rightly regarded as a subspecialty of its own right. In the past, it's been assumed that every ophthalmologist in the country can and should do cataract surgery. That's no longer the case. In fact, that's now been recognized in the curriculum, that actually trainees can choose to give up cataract surgery and assume a consultant position that does not expose them to the necessity to do cataract surgery. So in many ways, it is now the case that cataract surgery is a subspecialty. But yes, patients we now can offer patients a great result, independence from spectacles, low complication rates, and a very, very rapid rehabilitation. Again, we're moving towards, for example, dropless cataract surgery. So patients are able to have a very easy post-operative route by appropriate management of post-operative drops, recognizing perhaps that we may have overused antibiotics. Cataract surgery is an extremely safe procedure. Orthopedic surgeons, for example, will quote a joint infection rate of 1% to their patients. We can quote an infection rate probably about 100th of that. 1 in 6,000, 1 in 8,000 of endophthalmitis. Increasingly, we're moving towards methods of delivery of care, for example, of immediate sequential bilateral surgery.
That's what I was going to ask you about, yeah.
Bilateral cataract surgery, I should say. I offer that to a lot of my patients, both in the NHS and privately.
And what's the uptake on that?
Well, I chaired a symposium for Euchistris jointly with the Royal College of Ophthalmologists as we came out of lockdown. And immediate sequential surgery had been advocated for many, many years. But the honest truth is that many of us, including myself, hadn't really taken it up very widely. But it was seen as a way of coming out of the big lockdown problem.
And we obviously had a huge list then to go back to.
We had a huge backlog to get through, and it's the case that it's a very efficient use of resources to do both cataracts in the same sitting. And increasingly, we're offering that to more and more patients, and I'm finding fewer and fewer reasons not to offer it to patients. In fact, one of the most common reasons not to do is the patient doesn't like the idea of it, and that's a very rational and acceptable.
Yeah. And were you apprehensive in taking this new procedure up after COVID?
No, not really, because I've long done it, but only in a very small number of people. And of course, the nightmare scenario is an infection or a complication in both eyes. But complications are thankfully extremely rare, and some of those complications don't necessarily happen, for example, retinal detachment, in the first week after surgery, and therefore it's not necessarily rational to separate the two operations by 1 week in order to see if the patient gets a retinal detachment. Infection, postoperative inflammation, perhaps even cystoid macular edema are things that perhaps one would really hate to have in both eyes. But the honest truth is it's extremely rare.
And you were saying that one of the reasons you don't do it is because the patient doesn't want to do it. What reasons do they cite for not wanting to do it?
They're worried about having both eyes treated at once. Often patients do have slightly blurred vision for a day or two, sometimes due to postoperative macular edema, sometimes due to the glare of the operating microscope. If they have that in both eyes, it can be quite an unsettling couple of days. But in the days before I offered bilateral surgery, patients would ask for it, and I'd say, well, we can do it, but it's not something that we widely do. Some NHS units did not regard it as a very good use of resources, especially when second eye surgery wasn't necessarily usually undertaken, and therefore it was thought to be somewhat of a privilege to have the second eye done. And so we did put a bit of downward pressure on patients to have both eyes done at once. But once the penny dropped and we realized that actually, yes, it took longer than one eye, but it certainly didn't take as long as both eyes. And actually, if we look at doing perhaps 10 cases on a 4-hour NHS list, that's about one every 24 minutes. Actually, if you recognize that the actual surgical time of that 24 minutes is less than half, it becomes obvious that the issues aren't with the surgery itself, but with the processes around it. Turnover in operating theatres, getting patients in and out of hospitals, managing the flow of patients on a ward so that we don't have 10 patients waiting for surgery. These are problems which are largely logistical, and if you solve those, that's a real bonus, and that's the way that many units that now do achieve high-volume surgery have managed to do that.
And going back to the varied selection and designs of all the new lens technology, do you find it very time-consuming speaking to your patient and explaining the benefits, the advantages, disadvantages?
Yes, that is one of the reasons that's often quoted as being as a reason why, for example, multifocals or extended depth of focus lenses should be restricted to the private sector, because both more chair time is required and also a discussion of the various options. But actually, we're not in the position of being able to offer trifocals, continuous range of visions, or even EDOF lenses in the NHS. But increasingly, we can offer an enhanced monofocal lens. And if with mini-monovision, I tend to emmetropize the dominant eye and leave, 3/4 or 1 diopter of myopia in the non-dominant eye. That doesn't necessarily need a lot of discussion. I even know some senior consultants who've been doing that for years and actually haven't bothered mentioning it to the patients. They just do it.
Yeah.
Now, I would not advocate that, but I think that that's a pretty simple thing. And I tend to offer a very simple question. I say, are you interested in being less dependent on spectacles for near tasks after the operation? If patients say, no, I like my glasses, I don't mind my glasses, that's an end of the discussion. But actually, it's quite a brief discussion. Say, well, we have a way that we can minimize your need for glasses by slightly offsetting the two. If you compare the two eyes after the operation, you'll find that one's a bit better for distance, one's a bit better for near. By all means, do that, but don't do it sessionally, do it only occasionally. Let the brain fuse the two images, blend them, if you like. We sometimes call monovision blended vision. And yes, I think the more you do it, the better you get at abbreviating that discussion.
Yep.
And yeah, it's great to be able to offer these to our patients and make their quality of life better.
Yeah, and you're extremely lucky in terms of working both with the NHS and both privately that you can offer all of these options. Do you find it difficult sometimes in the NHS setting that you don't have the same availability that you do have in a private setting?
Yes, but it's not necessarily as clear-cut as you might think. I've heard managed healthcare described as America's greatest export. Now, in the past, we could confidently say to my insured private patients, you can come to the private hospital, you can have your choice of lenses. In fact, most of the insurance companies will not cover some of the more expensive lenses. So there's a top-up that the patients have to pay over and above. And I think most private hospitals have a package price for self-pay patients, and they set a price for insured patients. That generally includes an enhanced monofocal, sometimes one of the less expensive extended depth of focus lenses, and often, but not always, a toric intraocular lens. But if the patient wants a trifocal or a continuous range of vision or one of the more expensive extended depth of focus lenses, they have to pay a top-up. So that's a little bit like the discussion we're having in the NHS. I, for one, would like to see top-ups available in the NHS. I'd like NHS patients to be allowed to select a slightly greater range of lenses. I would acknowledge that is slightly opening up a whole can of worms, because there will undoubtedly be more chair time. What do we do about complications? For example, one of the criticisms have been of toric lenses that actually, if they need to be rotated, that's another operation which has to be covered under the NHS. Undoubtedly, that is true, but I think with appropriate management, it's actually very rare, or quite rare, that needs to be done. But I'm also a keen advocate of us as clinicians advocating for our patients. We should not, of course, we need to discuss price. We need to, we work in a publicly funded health service, and therefore we have a responsibility to use healthcare pounds wisely. but yet we are the doctors and we are the technicians, we are the nurses, we are the optometrists, we are the orthoptists that are trying to provide good standard of care for our patients. So I think we genuinely need to advocate for them, and I'm keen to try and do that.
Yeah, I think all practitioners are. We live in an age of a patient-centric world, and we have a duty of care to look after our patients to the best of our ability. So, it really is very, very promising to hear that.
I think that, if you like, the great benefit of the range of lenses we have for cataract surgeries is it allows us to improve the quality of life of our patients. Spectacles, of course, aren't the end of the world, but they're an inconvenience. And if it's an inconvenience that can be done away with relatively inexpensively and relatively simply, I think that's a huge advantage.
Time for a word from our sponsors, Mainline Instrument. Leading in ophthalmic innovation since 1997, Mainline Instrument supplies premium ophthalmology equipment from global manufacturers, including eye care, Oculus, Tord Pi, Tomei, Optomed, Huvitz, and Neats. From advanced diagnostics to surgical solutions, explore their products and services or book your in-clinic demonstration at mainline.co.uk. Mainline Instruments. Unmatched service, unbeatable products, unrivaled quality. I was reading a survey actually about spectacle independence and the age of different people, not just necessarily cataract people, but people at 20 years of age, 40, 60, 80, and their main desires and reasons for having corrective surgery and cataract surgery were kind of slightly different. So it's nice to be able to see quality of life affect kind of all different ages too as well.
I'm also, I have to say, in the lens versus laser debate for spectacle independence, 10, 15 years ago, there was quite a move towards clear lens extraction or refractive lens exchange with multifocal lens implantation. I think we've moved away from that because we've realized that actually it isn't necessarily as easy as it may seem. The commonest cause of lens explantation in the United States is for multifocal lenses following clear lens extraction in younger patients who are bothered by dysphotopsia. And actually, I'm quite a keen proponent of lens surgery, of laser surgery, corneal laser surgery, giving people multifocal corneas with extended refractive surgery techniques. I'm not a laser refractive surgeon, so I don't do these treatments myself. But increasingly, if a pre-presbyopic or just presbyopic patient comes to me seeking spectacle independence and they've got clear lenses, I'll often refer them to one of my corneal colleagues for a discussion about laser refractive surgery, either Presby Max or Presbeyond, depending on which laser. As we know, Dan Reinstein has pioneered this. Others have taken up the mantle with slightly different lasers, and I'm a keen proponent, and many of my patients, friends, and indeed family members have benefited from those technologies.
Yeah, they do tend to be a very difficult subset to manage, don't they? Those pre-presbyopes or just kind of entering presbyopia and maybe emmetropic too as well. They just tend to be a little bit more difficult to manage. Their expectations tend to be extremely high, and the refractive element tends to kind of be not on our side too as well.
Absolutely. And I think the taking out a clear lens is, I do a lot of it in my more elderly patients who have glaucoma, but I used to have a lower threshold to do clearer lens surgery. I once went to watch the late, great Manny Rosen operate, and he was doing relatively clear lens surgery in presbyopic patients or post-presbyopic patients. And I said, the penny dropped as I was operated. I said, this is clear lens surgery. And he stopped and he said, Philip, no lens is clear. And it is true that our presbyopic and post-presbyopic patients, they often have a little bit of lens opacity.
Natural.
And some of that will be visually significant. So there is definitely a benefit, but I also think that if the lens is absolutely clear, if patients have some residual accommodation, I think laser refractive surgery of the cornea is a very rational option in those patients.
I was going to ask you one other question too as well, Philip. I was over in America at the American Academy of Optometry, and I'm not sure if you've heard of the LAL intraocular lenses, the light adjustable lens. Have you come across those at all, where you can adjust the focus, maybe get the patient to try the IOL for 1 or 2 months and then come back and you can blend the vision for them, whether it be more distance orientated or near orientated?
Yes, I have. I mean, the light adjustable lens or light adjustable lenses have been around for a while, but they've definitely enjoyed a renaissance. Actually, at the ESCRS meeting in Copenhagen, I spent a time on the stand of the company offering the light adjustable lenses, and it's a very interesting technology. And of course, it offers benefits for treatment of postoperative unexpected refractive error. The problem is you have to put them in everyone, and the setup costs of the machine that does the light adjustment is extremely high. I believe it's of the order of £100,000, and so you have to have heavily invest in that. I think one of the models that might be employed is that actually have regional centres that offer the light adjustment, and to put in lenses more widely and then go to those centres, because I think in small units it's not affordable. I think it's a fascinating and potentially extremely useful technology, especially if you have a patient who you think might be have a unexpected refractive outcome. I think I've mentioned previously that we're getting better and better
Picking those up. Yeah.
And also the formula getting better and better at calculating the intended refractive outcome within a certain refractive range for patients who've had previous surgeries on the cornea. We're getting better and better at that. But yes, I think the light adjustable technology is extremely interesting. And once the price comes down, I think it might be something that's more widely
a viable option.
Yeah.
Good. Would it be okay if we move back to another topic you want to speak about, your micropulse? So it might be something that not everybody in our audience is aware of. So we tend to have quite a broad church of listeners. Would you be able to please describe what micropulse is and what you're involved in, what your interests in micropulse are?
So when I did my glaucoma fellowships between Moorfields and the Western Eye, a new laser technology had just come into use at Moorfields. That was the transscleral cyclophotocoagulation. It was a development of YAG cyclophotocoagulation, which was an advancement on the previous forms of cyclodestruction with cryotherapy, and previously before that other forms of laser. And it was a much less invasive, but still invasive method of cyclophotocoagulation. And also the penny drop that when we apply drops to the eye, we are deliberately employing a combination of inflow and outflow. And almost all of our surgical treatments still are outflow procedures, including cataract surgery, which is increasingly part of glaucoma surgery. The new MIGS devices, obviously trabeculectomy, tube surgery, these are all outflow procedures. And it's long been my thesis that actually we have perhaps ignored inflow surgeries. At about the same time, I was exposed to endoscopic cyclophotocoagulation. A machine came over from the States, the EndoOptics machine, which was an endoscopically applied method of cyclophotocoagulation. So both cyclodiode, as we abbreviate it to, which is transscleral cyclophotocoagulation with a continuous wave or thermal treatment, so-called cyclodiode, and endoscopic treatments. I've been doing those for about 30 years. Then in I think about 2014, 2015, a different modulation of laser energy delivery was introduced, which was rather than a continuous wave of laser energy, pulses of laser energy. The idea being that the heat doesn't build up as a result of the application of the laser energy, and therefore potentially the complications associated with transscleral cyclophotocoagulation, inflammation, perhaps these so-called POPs, which are potentially inflammatory and may cause pain, inflammation, and perhaps compromise the effect. So the so-called micropulse is a further development of continuous wave cyclophotocoagulation. We did it at my hospital from, I believe, 2016. And then interestingly, NICE had a look at the technology and felt that they were not sufficiently persuaded of the efficacy, or rather the evidence of the efficacy. They had no concerns about safety, nor do I. And I personally am persuaded of the evidence of efficacy. NICE came up with an initial guidance that was challenged. The challenge was not upheld. So in 2021, NICE ruled that micropulse cyclophotocoagulation in the United Kingdom had to be part of research studies. So most trusts have very efficient governance procedures now. My trust very rapidly suggested that we weren't able to continue doing it unless we set up a study. So I then went about setting up a national registry for which we sought and were ultimately given ethics approval. So for a national registry of this treatment, thereby fulfilling the NICE criteria that it is part of a research study. In December 2023, we started these treatments at Imperial. Imperial is the sponsor and the lead site. We now have 35 sites nationally in the UK that are gradually joining the study. And there's no particular protocol. It's a real-world study, which I think actually makes it, in some ways,
real-world
more powerful.
Experience.
Yeah. So it's a real-world study of the effects of micropulse transscleral laser therapy, or MPTLT as it's often abbreviated. And this will actually allow us to present results to NICE, which I believe will demonstrate that the efficacy will give evidence of efficacy that will allow the NICE decision to be challenged. And we hope that we'll continue to use this registry. We've already entered almost 100 patients into the registry. We think that with the addition of all the other units joining around the country, we hope that by the end of next year we'll have a minimum of 1,000 results, and perhaps even more. We used micropulse a lot during lockdown. It was a phenomenal tool to help our patients avoid incisional surgery for
when it
a
wasn't
period
available.
of time when no one was allowed to go into theatres. We did heaps of them. In fact, we did 255 in the 2 years before the NICE ruling. So we're just ramping back up now, getting more familiar again with the technology. There's a new probe design and new treatment parameters which make the results even better and even safer. And I think now I've published results from our unit comparing the micropulse with the continuous wave. And that was with the first probe and with the first set of treatment parameters. And when we published that, which was published in in 2024, there was a slight benefit of the older continuous wave treatment over the micropulse, but micropulse was safer. And I think at the time that might have been what I thought was the case. I'm now pretty convinced of the equivalence of the results in terms of the efficacy for pressure, but I do believe that micropulse is safer, it's better tolerated by patients, and can still be repeated very effectively, is minimally invasive, less painful, causes less inflammation, requires less post-operative follow-up. And so for all of those different reasons, I believe it's a significant advance. And again, it's my outside of the eye transscleral or inflow treatment of choice. I still also employ endoscopic treatments. And I personally like to combine inflow and outflow surgical treatments. So I combine ECP with, for example, the eye stent. And I think that adding inflow to outflow really adds an extra club to your bag, to use a golfing analogy, and gives more options. So I use micropulse as my default treatment from the outside. If I'm doing a cataract operation, I will often combine it with endoscopic treatment and a MIGS device like an eye stent. This way I think we can increasingly offer our patients independence of drops in the same way with cataract treatment. The same with cataract surgery, we want them to be independent of spectacles. the holy grail for glaucoma is to be independent of drops.
Yes. And that's one thing you mentioned earlier on too as well, the combination of both the cataract treatment and also the glaucoma treatment with MIGS and SLT. Can you tell me a little bit about MIGS technology, what it's done to the glaucoma population since its initiative?
With glaucoma surgery, we've been moving away from dependence on drops and making the drops kinder to the eye, so preservative-free drops. The advent of SLT, or selective laser trabeculoplasty, has helped us to offer drop independence as initial therapy. But actually, I'm also I feel very fortunate to be involved in some small way in the emergence of the revolution that is MIGS. It's perhaps not a revolution, but it's an evolution. And increasingly, we are doing these in the minimally invasive procedures to help reduce the number of drops the patient needs to take. I think we forget as
drops can be difficult for everybody.
Drops are difficult for everyone. They can be uncomfortable. They cause local and systemic side effects.
Hyperemia, redness, cosmetic unappeal.
Absolutely. Yeah. I mean, the most effective class of medications, the prostaglandin analogs, are associated with one of, I think, the most disfiguring issues, which is orbitopathy, fat atrophy. We all know the patients in our clinic who've been on prostaglandin analogs for many years, and they get this sunken appearance with dark rings around their eyes. We all know the beta blocker story and the fact that patients have, elderly patients have reduced exercise tolerance as a result of this, unbeknownst to them. They didn't put it together with their eye drops. So I think that the MIGS revolution has been a great addition to what we can add to patients. And I've heard it said, in fact, Professor Gus Gazzard is of the opinion, and I agree with him, that it's no longer acceptable not to offer MIGS or not to mention MIGS and have that discussion with patients.
I think medico-legally we're all probably a little bit kind of concerned about that too as well. But I remember in practice where I was seeing glaucoma patients, when there was preservative-free drops available, that their ophthalmologist wasn't supplying them. So they still had to go through the stinging, the hyperemia, not the enjoyment of using the drops, even though there was a solution there. So even though we have MIGS and we have SLT, does everybody get it? That would be the main concern I'd have.
Absolutely. And I think there can be little doubt that MIGS are effective. I think the discussion that has to be had is around cost effectiveness.
Yes.
Now, these are all expensive devices. These are devices that cost anywhere between £600 and £1,000 as a unit cost. But there's no doubt in my mind that they reduce the attendances, they reduce complications of other therapies, and although I absolutely advocate, and I don't think it's appropriate to do any MIGS-related research that does not involve patient-reported outcomes and cost-effectiveness parameters, I'm confident myself that MIGS will be validated in that regard and will be found to be cost-effective, certainly clinically effective, and certainly patient-centered. So I'm a big fan.
Yeah, and that's what we're all after, patient-centered care. Just going back away from the kind of the technical side, going to you. You've obviously been involved with UK's International Glaucoma Association, Royal College of Ophthalmologists, UKIRS, the list goes on. What drives you?
So different things. The college, of course, is a fantastic training organisation and advocates for the profession, but isn't a patient body. I was the chair of what used to be called the International Glaucoma Association. It's now Glaucoma UK. UKEGS is the conference arm of Glaucoma UK. And what's great about Glaucoma UK is it's an organisation for patients, which is relatively unique. All of the other organisations, fond of them though they are professional organisations. So UKISCRIS is a fantastic organisation which promotes best practice and training and teaching in cataract and refractive surgery, but doesn't specifically advocate for patients. So what attracted me to my involvement with the IGA that was Glaucoma UK as it is now is the fact that it's a patients organisation, and not just for patients, for their carers, for their families, for everyone involved in it. In terms of the Royal College, I've been actively involved in surgical training. In fact, my entire career, one of the first committees I joined was the surgical training committee at the Royal College of Ophthalmologists. I've continued to be involved in surgical training my entire career.
You do enjoy it, obviously.
I love training. In my early career, I would train more junior trainees. Now, being a more senior consultant, I'm fortunate enough to get the more senior trainees and fellows. And so, yes, in the past, I would take trainees through their very early cases, their first cataracts, their first capsulorhexis, their first lens implant, their first phacoemulsification. Now I'm taking more senior trainees through their first glaucoma drainage tube device, their first MIGS procedure, the cyclophotocoagulation. So, I think my aims have slightly morphed during that. But I feel very fortunate to have been involved with all of these organizations. Another organization I'm very fond of and had a deep connection with was the Royal Society of Medicine. The RSM is a fantastic organization, one that was hit hard by COVID, because it was an organization that the heart of which was in-person meetings. And I was on the council with Professor Roger Kirby, who led what he called a pivot to digital. And thankfully, that has helped the RSM, the Royal Society of Medicine, to survive and thrive.
Well, listen, thanks a lot, Philip. Really appreciate it.
Thanks for having me.